1. Clinical presentation and diagnosis. A 67-year-old man presents to the emergency department with fever, confusion, shortness of breath, and abdominal pain. He recently started corticosteroids for chronic obstructive pulmonary disease, COPD. His past medical history includes travel to rural Southeast Asia. On exam, he is febrile and tachypneic, with diffuse wheezing and an erythematous linear rash on his buttocks. CBC reveals marked eosinophilia. Sputum and stool samples show motile larvae. Which of the following is the most likely diagnosis? A. Ascaris lumbricoides. B. Strongyloides stercoralis. C. Schistosoma mansoni. D. Trichinella spiralis. E. Hookworm, Ancylostoma nicator. Correct answer, B. Strongyloides stercoralis. Explanation: this patient likely has Strongyloides hyperinfection syndrome, which occurs in immunosuppressed individuals, e.g. corticosteroids. Autoinfection cycle allows larvae to penetrate the GI mucosa or perianal skin, dissemination to lungs, brain, bloodstream. Symptoms: GI abdominal pain, diarrhea, pulmonary dyspnea hemoptysis, and cutaneous, pruritic, serpiginous rash. Rhabditiform larvae in stool and larvae in sputum support diagnosis. Why the others are incorrect? A. Ascaris lumbricoides may cause pulmonary symptoms during migration but doesn't cause hyperinfection or rash. Eggs, not larvae, seen in stool. C. Schistosoma mansoni causes portal hypertension and hepatosplenomegaly, not associated with pulmonary symptoms or hyperinfection. D. Trichinella spiralis causes myositis and periorbital edema after ingesting undercooked pork, not linked to pulmonary findings or larvae in stool. E. Hookworm can cause pruritic skin penetration, ground itch, and iron deficiency anemia, but not hyperinfection or CNS involvement. Question 2. Treatment. A 45-year-old woman from rural Colombia presents with intermittent diarrhea, abdominal discomfort, and a dry cough. She reports walking barefoot in the past. Physical exam shows a pruritic serpiginous rash on her thighs. CBC reveals eosinophilia. Stool microscopy shows rhabditiform larvae, and serology confirms Strongyloides stercoralis infection. What is the most appropriate treatment for this patient? A. Albendazole. B. Mebendazole. C. Praziquantel. D. Metronidazole. E. Ivermectin. Correct answer, E. Explanation: ivermectin is the first-line treatment for Strongyloides stercoralis. It inhibits glutamate-gated chloride channels, paralysis, and death of the parasite. It is superior to benzimidazoles, albendazole, in terms of efficacy for strongyloides. Duration of treatment may vary based on symptoms and severity, longer for hyperinfection. Why the others are incorrect? A. Albendazole, effective but less preferred for strongyloides. Used more commonly for ascaris, hookworm, and enterobius. B. Mebendazole, less effective against strongyloides than albendazole or ivermectin. C. Praziquantel, used for trematodes and cestodes, e.g. schistosoma, tinea, not nematodes like strongyloides. D. Metronidazole, antiprotozoal, e.g. for giardia and amoeba, not effective against helminths. Would you like the